Alright, so let's continue with neoplasia. So we'll look at various examples of neoplasms, the tumors, the benign epithelial tumors, malignant epithelial, benign mesenchymal, malignant mesenchymal, and terathomas, and also hemangiomas. Okay, so first we'll look at adenoma. Yeah, so um, let's take an example of the gross pathological specimen of a thyroid gland, yeah, with well circumscribed thyroid adenoma. So the gland is sectioned to review um, a round, well demarcated nodule, and usually it appears distinctly different from the surrounding thyroid tissue. And the nodule has a homogeneous tan to reddish color with a smooth cut surface indicating a benign tumor. And then the surrounding thyroid tissue usually appears darker and more irregular in comparison. Okay, so sometimes we use a ruler, usually we use a ruler for scale. Yeah, so basically with an image of thyroid adenoma, you could see, you already know that it's a benign tumor of the thyroid gland. And how will you differentiate the adenoma from a normal thyroid tissue? The adenoma is well circumscribed, round nodule with a distinct boundary, like I said earlier on, from the rest of the thyroid, and it has this tan to reddish appearance and a smooth cut surface, unlike the normal thyroid, which appears more irregular. So, but then what is a thyroid adenoma? It's a benign tumor of follicular cells in the thyroid gland, and it's typically non-functional but may cause hyperthyroidism if it secretes excess thyroid hormone as a toxic adenoma. And how does the thyroid adenoma present clinically? So most adenomas are asymptomatic; they are detected incidentally, and if functional, they can cause hyperthyroid symptoms like weight loss, palpitations, heat intolerance, and excessive sweating. So a palpable mobile solitary thyroid nodule may be found on examination. All right. So what are the differential diagnosis of a thyroid nodule? Like similar to that of adenoma, you can think of thyroid carcinoma, whether papillary, follicular, or anaplastic carcinoma, or multinodular goiter, thyroid cyst, and lymphoma of the thyroid. So, what investigations are needed to confirm a thyroid adenoma? Of course, we need an ultrasound to evaluate the nodule size, shape, and characteristics. And fine needle aspiration biopsy is also needed to rule out malignancy. The thyroid function test, like to detect the various levels, whether thyroid stimulating hormone T3 and also T4, helps to assess whether the adenoma is producing excess hormones. And radio iodine scan is also requested in some cases. So a hot nodule suggests a toxic adenoma, while a cold nodule may indicate malignancy. So how do we treat thyroid adenomas? Just observation if it is asymptomatic and non-functional, but surgical excision is needed, as lobectomy if the adenoma is large, symptomatic, or suspicious of malignancy, and radioiodine therapy or antithyroid drugs if the adenoma is hyperfunctioning. All right, so that's it for adenoma of the thyroid gland. Okay, so let's go on to adrenal adenoma. Okay, so for adrenal adenoma, um, when you take a gross pathological specimen of adrenal adenoma, it appears well circumscribed. You know, it's a benign tumor of the adrenal gland, and it's round. It has this yellow tan nodule with smooth cut surface, and it's distinctly different from the surrounding adrenal tissue, which is more irregular and fatty. So usually just, of course, you use a ruler um, just for scale. Yeah. So what's an adrenal adenoma? It's a benign tumor, like I said, arising from the adrenal cortex, and it can be non-functional, as asymptomatic, and functional, that's hormone secreting. So how does an adrenal adenoma appear grossly? It's well defined, round and encapsulated lesion, and yellow tan color is due to the presence of lipid-rich adrenal cortical cells. The smooth cut surface is distinct from the surrounding adrenal tissue. So what are the types of functional adrenal adenomas? You have the cortisol secreting adenomas, which causes Cushing syndrome. Aldosterone secreting adenomas in Conn's syndrome, which causes primary hyperaldosteronism, and also androgen secreting adenomas, which causes virilization, that's hirsutism, deep voice in females. Okay, so what are the clinical features of adrenal adenomas? You have non-functional adenomas, usually asymptomatic, is detected incidentally on imaging as incident talomas, as what we normally call it. So functional adenomas, we have cortisol excess, that's the moon phase symptom, and central obesity, striae, hypertension, and this is usually seen in Cushing syndrome. And with aldosterone excess, there's usually hypertension, hypokalemia, metabolic alkalosis, that's in Conn's syndrome. And aldosterone excess, we have hirsutism and virilization in females. Right, so how is the adrenal adenoma diagnosed? It's through imaging like CT, MRI, which shows well circumscribed low density mass, hormonal testing, dexamethasone suppression test for Cushing syndrome, and plasma aldosterone renin ratio for Conn's syndrome, and then DHEAS levels for androgen secreting tumors. And what's the treatment for adrenal adenomas? Of course, the same formula. Observation if it is small, less than 4 cm, and non-functional too. And surgical removal, adrenal excision. So that's adrenalectomy. So that's when it's large and functional and suspicious for malignancy. Alright, so medical management, we have spironolactone for aldosterone secreting adenomas, ketoconazole for cortisol overproduction. Okay, so that's it for adrenal adenomas. Okay, so next we are going to look at another aspect of the adrenal gland. Then from there we go to the dysplastic squamous epithelium. So with the adrenal gland, okay, so just a quick summary. So we know it's a benign tumor of the adrenal, yes, that's for adrenal adenomas, benign tumor of the adrenal gland, and the tumor is well demarcated, appearing yellow to yellow tan lesion or round yellow tan lesion embedded within the adrenal tissue, and the surrounding adrenal gland is present, showing a distinct contrast between the normal and the neoplastic tissue. So one thing is that for most of the adrenal adenomas, yep, similar was circumscribed and yellow tan tumors and appears to be more central capsulated lesion within adrenal gland compared um, with other images, more prominent and large, and the tissue processing stain will be slightly different, and which will affect the color precipitation. But the hallmark appearance of adrenal adenomas remains consistent. So, with the pathological features macroscopically was circumscribed around lesion, yellow tan due to high lipid content, and homogeneous cut surface, sometimes with hemorrhage, and with the microscopic, there's a uniform adrenal cortical cells, low mitotic activity, distinguishing it from adrenal carcinomas. Now the functional and non-functional. With the non-functional adenomas, they are usually asymptomatic and discovered incidentally, and with the functional adenomas, that's when you have the Cushing syndrome, Conn's syndrome, and virilization in females. So the Cushing syndrome, that's when you have excess cortisol secretion, aldosterone secreting tumors, that's in Conn's syndrome, and androgen secreting in virilization in females. So the diagnosis, like I said, through imaging, could have your CT scans, low density lesion, or the demarcated lesion is seen in the CT. With the MRI, you have the iso intense or hyper intense on T1 weighted imaging, and the biochemical test, we have the hormonal levels, cortisol levels, aldosterone, and DHEAS in being increased. So the treatment, we have this one of functional adenomas, which we just observe. But with a large functional adenoma, surgical excision is requisite. That's adrenal lectum. Okay, so that's it for that's the summary of the adrenal adenomas. So now let's move on to this plastic squamous epithelium lesions. Right, so let's go on with this plastic squamous epithelium. So this when you take a typical slide, histopathological slide H&E stain of this plastic squamous epithelium, there are preconscious changes in the stratified squamous cells that you can see. So it's characterized by disordered epithelial growth cells, epithelial cell growth with various degree of atypia. There's a architectural disturbance, loss of normal stratifications. The nuclei appear crowded and irregularly arranged. And then also one thing that you realize is that there is thickened irregular epithelial layer, and the cytological changes to, there's an enlarged hyperchromatic nuclei, that's the dark staining, and there is pleomorphism, that's the variation in the size and shape of the nuclei. And there's an increased nuclear to cytoplasmic ratio, and there's abnormal mitotic figures, which is suggestive of high cell turnover. So that's for the cytological atypia. And there's also loss of cell polarity. So normal basal to surface differentiation is disrupted, and also the basement membrane is intact, it's non-invasive. That is unlike the carcinoma in situ or invasive carcinoma. These plastic cells do not breach the basement membrane. Right? So dysplasia is considered as a preconscious lesion and may progress to squamous cell carcinoma if left unchecked. So mild dysplasia, as like lower third of epithelium is affected, moderate dysplasia 2/3 of the epithelium is affected, and severe dysplasia That's the carcinoma in situ. There's a full thickness epithelium involvement. So the common sites are the cervix, which is cervical intraepithelial neoplasia, and esophageal dysplasia. That's squamous dysplasia. Esophageal squamous cell dysplasia. Oral mucosa too could happen over there as leukoplakia or erythroplakia, as oral squamous cell carcinoma in the skin. Actinin keratosis. That's also squamous cell carcinoma in situ. So diagnosis is via biopsy, histopathology, and also the risk assessment. There's high grade dysplasia, which warrants close monitoring. With the treatment for mild dysplasia is just observation and risk factor modification like smoking cessation, um, human papillomavirus vaccination. But for the moderate to severe dysplasia, there could be surgical excision, laser ablation, and or topical therapy. It's dependent on the site too. Okay, so basically, dysplasia, like I said, is a term that literally means disorderly growth in epithelial tissue. So it's a potential reversible change characterized by loss of uniformity of the individual cells and of their architectural orientation. There's a loss of polarity with cells that look like basal cells appearing in the uppermost or topmost layers. So other features of the cells are those of anaplasia. And when dysplasia involves the entire thickness, that's carcinoma in situ or intraepithelial carcinoma. And dysplasia is usually found adjacent to invasive carcinoma, and it predates epithelial cancers and may progress to cancer. It may completely disappear upon removal of the offending agent when the changes are mild or moderate, and in such cases the epithelium reverts to normal. Alright, so more on the histopathological analysis. So for a low grade dysplasia, it's like IN1. It's also known as mild dysplasia in stratified squamous epithelium. And for this mild dysplasia or low grade intra epithelial neoplasia, IN1, the involvement of the lower third of the epithelium, there's involvement of the lower third of epithelium. So atypical cells are restricted to the basal and the parabasal layers, and the upper layers maintain normal maturation. So with mild cytological atypia, there's a large hyperchromatic nuclei, mild pleomorphism, variation in nuclear size and shape, and there's increased nuclear to cytoplasmic ratio, but not extreme, and there's preserved polarity and stratified and stratification. So the epithelial architecture remains relatively organized with no loss of basal polarity, and there are few mitotic figures too. That's normal mitosis may be seen in the lower third of the epithelium, and there's intact basement membrane, so no invasive or invasion into the underlying stroma, which distinguishes it from carcinoma. So with the clinical implications and rates of progression, mild dysplasia as the intraepithelial neoplasia, one low grade intraepithelial neoplasia, is considered a reversible precancerous lesion, and the common causes are human papillomavirus infection like cervical intraepithelial neoplasia 1, chronic irritation or inflammation like smoking in lung dysplasia, gastroesophageal reflux disease in Barrett's esophagus, and ultraviolet damage as actinic keratosis, and also risk of progression, that's mild dysplasia. It's reversible or progress to intraepithelial neoplasia 2, or the moderate or severe, severe, that's 3 dysplasia. It's if it is left untreated, severe dysplasia may lead to carcinoma in situ and invasive carcinoma. So the management and follow-up is simple. It depends on the location, the etiology. Human papillomavirus related lesions, there's observation, vaccination, regular pap smear, and with esophageal dysplasia, like Barrett's esophagus or GERD related, there's endoscopic monitoring. And with oral dysplasia like leukoplakia, there's you eliminate the risk factors like tobacco and alcohol. All right, so to let's move on to the moderate intraepithelial neoplasia. So that's the IN2. It is also known as the moderate dysplasia in stratified squamous epithelium. That's if you have one in stratified squamous epithelium. There's the key morphological or the histological features of moderate dysplasia is that there's involvement of the lower and middle thirds of epithelium. So atypical cells extend beyond the basal layer, affecting up to 2/3 of the epithelial thickness. So there's partial loss of normal maturation. There's increased cytological atypia, so more pronounced nuclear pleomorphism. And there's variation in the nuclear size and shape. There's irregular hyperchromatic nuclei with coarser chromatin and higher nuclear to cytoplasmic ratio compared to intraepithelial neoplasia 1. So there's disorganized epithelial stratification and loss of normal layering with immature cells present in the upper layer. So polarity disruption to occurs and cells may not be properly aligned. There's increased mitotic activity with frequent mitotic figures even in the middle layers, and there's no abnormal mitosis reaching the surface, but the basement membrane remains intact and no stromal invasion, which differentiates it from carcinoma. And with the clinical implications and risk progression, moderate dysplasia is also a precancerous lesion with higher risks of progression than intraepithelial neoplasia 1. So the common causes is also similar. There's human papillomavirus infection, cervical intraepithelial neoplasia 2, and chronic inflammation or irritation, as in gastroesophageal reflux disease and esophageal dysplasia. There's also smoking and carcinogen exposure in lung or oral dysplasia. And with the risk factors of progression, intraepithelial neoplasia 2 is more likely to progress to 3, which is a severe dysplasia. It is step closer to carcinoma in situ, and regression is still possible though, especially in young individuals with strong immune responses. And with the management and follow-up, it depends on the location and the etiology. So human papillomavirus related lesions, as close we have to consider closer monitoring, biopsy and excision of if persistent esophageal dysplasia, seen Barrett's esophagus or GERD related. There's endoscopic surveillance or ablation, and oral dysplasia like leukoplakia. There's risk factor modification. You have to stop smoking, alcohol, biopsy or surgical excision. So let's do a quick comparison between the epithelial neoplasia 1, 2, 3, which is a mild dysplasia, moderate dysplasia, or severe dysplasia. And we look at several parameters. So with the feature like epithelial neoplasia, the lower 1/3 is affected. The lower to middle parts, that's 2/3 for moderate dysplasia, and there's full thickness, nearly full thickness for severe dysplasia. For nuclear atypia, it's mild and it's moderate for moderate dysplasia, and it's severe for intraepithelial neoplasia 3. For mitosis, no, there's few, and the basal layer is meaning seen over there. but there's increase and mild layers being involved in the moderate dysplasia, and severe, frequent, and upper layers to are being involved, with the polarity is preserved in mild dysplasia and is partially lost, but it's mostly lost in the severe, mildly, partially in moderate dysplasia, and the basement membrane is intact for all of them. All right, so that's the comparison. But let's focus on the severe intraepithelial neoplasia 3. It's also known as the severe dysplasia or carcinoma in situ. All right, so we'll quickly go through that, and then so with that is the full thickness atypia, which involves nearly the entire thickness of the epithelium. There's very few normal mature cells at the surface, so there's marked cytological atypia, which is pronounced nuclear pleomorphism, variability in nuclear shape and size, and it's hyperchromatic nuclei. That's a dark staining due to dense chromatin and high nuclear to cytoplasmic ratio. So there's lots of stratification and polarity. The cells appear disorganized with loss of normal layering. Immature basal cells, like basal-like cells, present throughout the epithelium, and there's increased atypical mitosis. So frequent mitotic figures can be seen in the upper layers, and there's abnormal mitotic forms, which suggest high proliferation proliferative activity. So the basement membrane remains intact and no stromal invasion, and this differences is from invasive carcinoma, with the clinical implications and risk of progression. Severe intraepithelial neoplasia 3 is a high risk precancerous lesion, which often is synonymous with carcinoma in situ. It causes its common causes are from human papillomavirus infection, like cervical intraepithelial neoplasia 3, chronic inflammation and Guillain-Barré esophagus dysplasia, and also tobacco alcohol risk factors, like in oral leukoplakia, progression to squamous cell carcinoma. So with the risk of progression, there's very high risk of progressing to invasive carcinoma if left untreated, and immediate intervention is required. And with the management and follow-up, it actually depends on the location and etiology. So cervical dysplasia and requires excision biopsy, LEP, cone biopsy or ablation, and esophageal dysplasia, embarrassed esophagus, endoscopic resection or radio frequency ablation is needed. Oral dysplasia or leukoplakia, surgical excision is needed to prevent malignancy. Right, so a quick recap. The basement membrane remains intact in all the three, but invasive carcinoma, it's breach. So that is for moderate dysplasia and severe dysplasia, and also comparing that to invasive carcinoma, with the polarity is partially lost with moderate dysplasia, like I said, mostly lost in the severe, but completely lost in invasive carcinoma. And with mitosis, there's increased mitosis in moderate. There's even up to the mid layers, and frequent even up to the upper layers when it comes to mitosis, but it's abnormal and frequent in invasive carcinoma. It's very severe when it comes to nuclear atypia, severe for both the severe dysplasia and invasive carcinoma, but moderate for intraepithelial neoplasms or neoplasia 2. And with epithelial involvement, the lower and the middle, or the 2/3 of the layer, and full thickness, nearly full thickness, but beyond the basement membrane for invasive carcinoma. Alright, so let's go on to the uterine cervix squamous cell carcinoma. So with a gross pathological specimen showing an advanced case of squamous cell carcinoma of the uterine cervix. That's the most common cervical malignancy. So with the gross features, there is exophytic or ulcerative mass, and it's irregular fungating tumor mass replacing the normal cervical tissue, and the ulceration and necrosis is visible on the surface. There is infiltrating growth, and the tumor invades the underlying cervical stroma. So it may extend to adjacent structures such as the vagina, parametrium, and the bladder. In advanced cases, there is firm whitish tan appearance, dense desmoplastic stroma, serous reaction, and also foci of necrosis and hemorrhage is seen within the tumor. So distorted endocervical canal too is seen, and tumor obstructs the cervical os and may cause hydronephrosis in advanced cases due to ureteric compression. Alright, so pathogenesis of cervical squamous cell carcinoma, usually from human papillomavirus infection, of which is high risk. The high risk types are 16, 18, even 31, 33, 45. Viral oncogenesis E6, E7, and inactive P53 and RB retinoblastoma tumor suppressor genes, and leading to uncontrolled cell proliferation, and also precursor lesions like the cervical intraepithelial neoplasia in squamous cell carcinomas, and the mild dysplasia 1, and cervical intraepithelial neoplasia 1 and 2. So from the mild dysplasia to moderate dysplasia to severe dysplasia. So the risk factors: multiple sexual partners, early sexual activity, smoking, immunosuppression, HIV, low socioeconomic status. Or the clinical implications: we have symptoms: postcoital bleeding, irregular vaginal bleeding, and malodorous vaginal discharge, pelvic pain, hematuria, constipation in locally advanced cases. And with the complications, we have the bladder invasion, fistula formation, and also uterine obstruction in hydronephrosis, and renal failure, which is a common cause of death. With the staging, the figure staging, we have stage 1 to stage 4. Stage 1 is confined just to the cervix. Stage 2 beyond the cervix but no pelvic wall involvement. And stage 3, we have the pelvic wall or lower 1/3 of the vagina. And the stage 4, the resistant metastasis, including bladder, rectum, lungs, and even the bones. On the treatment with early stage, we have cervical resection like radical hysterectomy plus pelvic lymphadenectomy, and locally advanced ones can do a chemoradiotherapy, like cisplatin based. And with the metastatic disease, it's usually palliative chemotherapy as immune checkpoint inhibitors like pembrolizumab in PD-L1 positive tumors. Alright, so comparing cervical intraepithelial neoplasia 3, that's severe dysplasia, with squamous cell carcinoma, the basement membrane is intact for severe dysplasia but breached in the invasive growth in the squamous cell carcinoma. Atypical mitosis, severe or very severe with necrosis when it comes to squamous cell carcinoma. And there is full thickness dysplasia in the growth pattern, but there's infiltration and ulcerative mass or ulcerated mass in the squamous cell carcinoma. And the treatment basically it's excision, LEEP, cone biopsy, or for squamous cell carcinoma is surgery and also chemoradiotherapy. So a key takeaway is what then you should remember is that cervical squamous cell carcinoma is preventable malignancy through routine pap smear and human papillomavirus vaccination, and high risk types of the HPV like the 16 and 18 are primary causative agents, and with severe dysplasia is the last stage before squamous cell carcinoma, and early detection is crucial. Alright, so more on squamous cell carcinoma histology. So microscopic features of squamous cell carcinoma um, of the cervix. There is invasive growth, and the tumor cells breach the basement membrane, infiltrating the underlying stroma, and keratin pills keratin pills are seen in well differentiated squamous cell carcinoma. So they are the concentric um, layers of keratinized squamous cells forming eosinophilic pink structures, and these plastic squamous cells are enlarged pleomorphic nuclei with hyperchromasia, with increased nuclear to cytoplasmic ratio and prominent mitotic figures, including a typical mitosis, this desmoplastic stromal reaction, and dense fibrostroma surrounding invasive tumor nets. There's also inflammatory cell infiltration, which is lymphocytes and plasma cells infiltrates. Yeah, so the lymphocytes and plasma cells infiltrate the tumor microenvironment. There's also loss of normal epithelial maturation. So unlike the normal squamous epithelium, the squamous cell carcinomas showed disordered maturation and loss of polarity. So let's compare that with severe dysplasia. So with invasive squamous cell carcinoma, basement membrane is breached, that's invasive growth. With cellular atypia, it's severe with necrosis also, but dysplasia, basement membrane is intact. Cellular atypia is very severe. Mitotic figures are present in dysplasia. With invasive squamous cell carcinoma is actually frequent and atypical, and with inflammation it's minimal but very prominent. Minimal in severe dysplasia but very prominent in invasive squamous cell carcinoma. And keratin pills are absent in severe dysplasia but present in well differentiated squamous cell carcinoma. Right, and the clinical correlations: human papillomavirus associated pathogenesis, the HPV E6 protein inactivates the tumor suppressor gene P53, which promotes unchecked, thereby promoting unchecked cell division, and the E7 of the HPV protein, it inactivates the RB gene, which also has tumor suppressor gene, the retinoblastoma tumor suppressor gene, leading to loss of cell cycle control. So screening with pap smear, it's really important for early detection, and it detects the dysplastic cells in pre-invasive stages, and colposcopy or biopsy as confirmatory or high-grade lesions and squamous cell carcinoma. And with P16 immunostaining is a marker for HPV-driven dysplasia. So quick one on the management based on the squamous cell carcinoma differentiation. So if it is well differentiated squamous cell carcinoma, the treatment is usually surgery and radiation, but the characteristics of that one is there you can see prominent keratin pills and low mitotic activity. But for moderately differentiated squamous cell carcinoma, there's less keratinization and increased mitotic figures. The treatment is chemotherapy. But poorly differentiated squamous cell carcinomas, there is no keratinization, there's aggressive high mitotic rate, and the treatment is chemo, radiation, and also palliative care. Okay, so the key takeaways are squamous cell carcinoma of the cervix arises from three from the severe dysplasia or cervical intraepithelial neoplasia 3, which is driven by high risk human papillomavirus infection, so type 16 and 18, and pap smear with human papillomavirus vaccine. So Gardasil, Cervarix are key prevention strategies, and invasive squamous cell carcinoma is diagnosed by histopathology, showing keratin pills, nuclear ETPI, and also stromal invasion. Alright. Okay. So we'll go ahead with another squamous cell carcinoma of the cheek. So if you see a case like that, you see that there are irregular ulcerated lesions on the cheek, and the lesion appears scaly, crusted, and ulcerated with raised edges. And there's central necrosis, yes, present. It may be present. There's indurated and erythematous borders, and the lesion is firm on palpation, surrounded with erythema and mild inflammation also seen. And common is usually common in the elderly and sun exposed areas, and the risk factors are chronic UV exposure, fair skin, advanced age, and immunosuppression. The differential diagnoses include actinic keratosis, that's pre-malignant rough scaly patches, and basal cell carcinoma, that's pearly road borders, less ulcerations, kerato acanthoma, that's rapidly growing but may regress, and melanoma is pigmented irregular lesion which needs dermoscopy. So the risk factors of squamous cell carcinoma with respect to that of the cheek, on the cheek, its development has to do with chronic UV exposure, sunlight or tanning beds, and immunosuppression, for example in organ transplant, HIV/AIDS, a wound, chronic wounds or burns, and Magellan ulcers, and also human papillomavirus infection, especially type 16, 18, in mucosal squamous cell carcinomas, and exposure to carcinogens like arsenic, radiation, industrial chemicals. So the diagnosis and management, we have biopsy, which is a gold standard, which confirms the squamous cell carcinoma with histopathology, and also surgical excision is a first line treatment with wide local excision with clear margins. So MOH surgery or that one, most surgery, MOH surgeries, it's for high risk facial squamous cell carcinoma to prevent function, to preserve the function, and also radiotherapy is needed for inoperable cases or adjuvant therapy. Immunotherapy or chemotherapy for metastatic squamous cell carcinoma, like PD-1 inhibitors like semi-PLAB. So one thing you have to remember is that squamous cell carcinoma is an invasive ultraviolet induced malignancy, and early detection and surgical excision provides the best diagnosis. Right, so with squamous cell carcinomas, with the keratin pills, their keratin pills are just concentric with the histology or histopathology, H&E staining. They're concentric layers of eosinophilic keratin, is produced by malignant squamous cells, a hallmark of all differentiated squamous cell carcinoma. And dysplastic squamous cells are enlarged pleomorphic nuclei with hyperchromasia and abnormal mitotic figures indicating uncontrolled proliferation. So infiltrative growth pattern, you have malignant cells which extends beyond the basement membrane into deeper tissues, endosmoplastic stroma, fibrotic tissue response to invasive carcinoma, and inflammatory cell infiltrate too. So lymphocytes and plasma cells surround the tumor nets. For the clinical relevance, the keratin pills have good differentiation, and the presence of keratin pills suggests well differentiated squamous cell carcinoma, which generally has a better prognosis compared to poorly differentiated tumor. Aggressiveness and metastatic risk include poor differentiated squamous cell carcinoma, which lacks keratin pills and inhibits small nuclear polymorphism and anaplasia, and it can metastasize via the lymphatics, particularly in high-risk sites like the lips, ear, and mucosal surfaces. With the histological grading system, we have well differentiated and moderately differentiated and poorly differentiated. With a well differentiated squamous cell carcinoma, there is prominent keratin pills, minimal polymorphism, and with moderately differentiated, we have some keratinization and more nuclear atypia. And with more differentiated squamous cell carcinomas, we have the minimal keratinization, high mitotic activity, and aggressive nature. And one thing you have to remember is the presence of keratin pills is a defining feature of squamous cell carcinoma and suggests well differentiated tumor pathology, which generally correlates with a better prognosis. Alright, so let's look at basal cell carcinoma. And an illustrated it's one on, let's say, the upper lip, an illustrated lesion on the upper lip. So the telangiectatic nodule, it appears small, firm, pearly nodule with telangiectasias, which are visible blood vessels. And there's a central ulceration or with road borders, often described as rodent ulcer. Okay, so that's for the basal cell carcinoma, ulcerated lesion on the upper limb. So a common location is typically the sun exposed areas like the face, nose, upper lip, forehead, and there's slow growth or local invasion. So basal cell carcinoma is locally invasive but rarely metastasizes and can cause tissue destruction if untreated. So the pathogenesis and risk factors arises from basal layer of the epidermis and associated with mutations like the hedgehog pathway dysregulation. Okay, it's like PTCH1. So the major risk factors are chronic UV exposure, especially UVB, and fair skin, albinism, xeroderma pigmentosum, immunosuppression, for example, in transplant patients, and ionization radiation exposure. Histopathology, we have the basaloid cell nest, so dark staining basaloid cells with palacidin nuclei at the periphery. So peripheral palacidin or palacidin and retraction artifacts could be seen too. So the tumor cells are arranged in a linear fence-like pattern at the border and clear separation, that's retraction from surrounding stroma. So mucinous and myxoid stroma too is seen, and characteristics of basal cell carcinoma aiding in diagnosis. So with the management and treatment, the first line we have the surgical excision with clear margins, like the most microscopic surgery for high risk areas, and alternative treatments include electrodesiccation and curettage, like ED&C, for small superficial lesions. So with the topical 5-fluorouracil and imiquimod for superficial basal cell carcinoma, we have radiotherapy for patients who are not surgical candidates. So these ones, the hedgehog pathway inhibitors like the vismodegib and sonidegib, they are for locally advanced or metastatic basal cell carcinoma. So basal cell carcinoma is the most common skin cancer, and typically appearing as pearly or straighter lesion with road borders and telangiectasias. While it's locally aggressive, it has a very low metastatic potential, and early surgical intervention ensures high cure rates. Right, so with the histopathology of basal cell carcinoma, the key morphological features are characteristic of the common skin malignancy, and they are the basoid and basaloid tumor cell nests. So these are dark staining basaloid cells arranged in nests, or lobes. They are high. They have high nuclear to cytoplasmic ratio, peripheral palisading, which is the tumor cells at the periphery aligned with the palisading pattern, resembling a fence. And there's retraction artifact, is a clear space retraction clefting between the tumor and surrounding stroma, and this helps differentiate the basal cell carcinoma from squamous cell carcinoma. So the mucinoid and myxoid stroma, so surrounding the tumor nests and contributing to its invasive behavior. So there is lack of keratinization, and unlike the squamous cell carcinoma, the basal cell carcinoma does not form keratin pills. And diagnostic importance, we have the definitive diagnosis, which is made via biopsy and histopathological examination. So palisading or palisading nuclei and retraction artifact are hallmark features of basal cell carcinoma, and the clinical correlation seen in sun exposed areas like the face, nose, and upper lip, and locally invasive but rarely metastasizes. Alright, so more on the anterior view of the histopathology of basal cell carcinoma. And like I said, you can still see the basaloid tumor cell clusters. So there's dark hyperchromatic nuclei with scant cytoplasm. Cells form irregular nests and lobes invading the dermis. There's peripheral palisading. The tumor cells nuclei align in the palisading arrangement at the periphery, and also retraction artifact or clefting. There's a space between the tumor cell nest and the surrounding stroma, and this key distinguishing feature of the basal cell carcinoma. And mucinous and fibrous stroma, there's loose connective tissue surrounding the tumor nest, and there's absence of keratinization, which helps differentiate it from squamous cell carcinoma. So clinical relevance, the basal cell carcinoma is locally invasive but rarely metastasizes, and most commonly affects skin exposed areas, particularly the head and the neck. Alright, so let's go on to something else like navy on the chest skin. So there are this particular one, there are multiple pigmented nevi or moles scattered across the chest. And the key features are even pigmentation, light to dark brown, macules or papules, as well defined borders or symmetric shape with clear margins, and multiple locations across the chest associated hair growth, and some nevi may have hair and also clinical relevance. There are nevi moles. Um, they're actually benign proliferations of melanocytes, and most are harmless, but some may um, transform into melanoma as a malignant melanoma. The ABCD rule helps identify the atypical or dysplastic um, nevi or moles. And the A is asymmetry, there's border irregularity, there's color variation, there is the diameter more than 6 millimeters, and also evolution could occur, which is the changes, size, shape, color, and symptoms. Okay, so more on the nevus or the nevi or moles. The H and E staining, you realize there'll be melanocytic proliferation in the epidermis and the dermis, and the nests of the nevus cells in the epidermis and the dermis will be seen. So there's melanin granules, brown pigments in some cells, small round nevus cells too with minimal pleomorphism. There's absence of mitotic figures, which suggests benign nature, and maturation with depth, like cells become smaller and less pigmented as they grow deeper. And common melanocytic nevus is benign and differs from malignant melanoma, which shows cell atypia, mitotic figures, and loss of maturation. So nevi can be junctional, compound, or intradermal depending on cellular location. Okay, so let's move on to malignant melanoma, which is highly aggressive skin cancer arising from melanocytes. So the key features using the ABCDE rule, we have the asymmetry, which is irregular shape, one half different from the other, and also the border is uneven, and C is for the color, but the borders uneven is jagged and poorly defined edges. So the color is there's varied pigmentation from black, brown, blue, red, or white areas. The diameter is often more than 6 millimeters and can be smaller. The evolution, the sizes change. So there are changes in size, shape, and color over time. And the clinical importance, early detection is very critical. Melanoma has high metastatic potential, especially if it has invaded deeper layers of the skin, and the risk factors include ultraviolet exposure, fair skin, family history, dysplastic nevi. And with the diagnosis, we have excisional biopsy with histopathology and histoimmunochemistry like S100, HMB 45 melan, and A. In the treatment, we have the surgical excision, wide margins, possible immunotherapy, for example, checkpoint inhibitors like pembrolizumab. Alright, so more on the malignant melanoma. Advanced stage melanoma, you see multiple irregular pigmented lesions, which is suggestive of possible satellite metastasis, which indicates advanced stage of melanoma, and that's the malignant melanoma. And the clinical features, there's irregular darkly pigmented lesions with asymmetry, satellite lesions which are smaller pigmented spots near the primary tumor. There's crusting and ulceration indicative of aggressive growth, and there's erythematous reddish areas suggesting local inflammation. or invasion. The prognostic concerns the presence of the satellite lesions suggests regional lymphatic spread or poor prognostic indicator, and Breslow thickness or tumor depth and Clark level are crucial for staining. Metastatic potential is very high and requiring urgent intervention. Intervention. So the next steps, which is very urgent, is excisional biopsy with immunohistochemistry as S100 HMB 45 melan A and sentinel lymph node biopsy to assess the spread. The staging workup, we have the PET scan, CT for metastasis, and the treatment of surgical excision, immune checkpoint inhibitors like pembrolizumab, nivolumab, and target therapy if BRAF mutation is positive. Okay, so another thing we could look at to when it comes to the histopathology specimen of malignant melanoma, the gross specimen of an excised tissue, skin and subcutaneous tissue. You observe that there is central pigmented lesion with dark brown discoloration surrounding normal appearing dermal and subcutaneous tissue, and thickness measurement is crucial as a Breslow depth. So with the staging considerations, the Breslow thickness or depth of invasion less than 0.8 millimeters is low risk. 0.8 to 1 millimeter, that's a sentinel lymph node biopsy, which is indicated. So 1 millimeter, which is high metastatic risk. In illustrations and mitotic rates, the presence worsens prognosis, and also lymphatic and hematogenous spread to the sentinel lymph node involvement, resistant metastasis like the limbs, the lungs, the liver, and the brain. And with the steps involved in diagnosis and treatment, histopathological examination, H&E, immunohistochemistry, S100, HMB, 45 melan A. So molecular testing to whether BRAF, NRAS, KIT mutations for targeted therapy, and surgical margins like wide excision with appropriate margins, and also systemic therapy, checkpoint inhibitors like pembrolizumab, nivolumab, and targeted therapy if BRAF is present. Okay, so that's something about malignant melanoma. Okay, so now let's jump to the lungs and see something about the squamous cell carcinoma of the lungs. With the gross pathology, you see it's a common type of non-small cell lung carcinoma, and it's usually centrally located white tan mass, firm mass, which is typical of the squamous cell carcinoma of the lungs, and there's cavitations and bronchial involvement is frequent in this type of carcinoma. Okay, so agent lung parenchyma shows emphysema and anthracotic pigment. It's a testing smoking related damage. An important features of pulmonary squamous cell carcinoma is the location. So it's usually central, which often arises in the bronchi, and the histology. There is keratin pills intracellular bridges, and also associations. We have um, strongly linked to smoking, and the common mutations like PT53, um, FGFR1 amplification, the paraneoplastic syndrome like parathyroid hormone related peptide hypercalcemia, diagnosis and workup of bronchoscopy and biopsy, squamous cell carcinoma confirmation, and immunohistochemistry. We have the P40, P50, P63 positive, um, and these are markers for squamous cell carcinoma, and with the TTF1 negative rules, it rules out adenocarcinoma. And with the molecular testing, we have limited targeted therapies, unlike the adenocarcinomas. And with the CAT scan and PET scan, it's just for the staging of the metastasis. With the management options, we have early stage, which is 1 to 2. That one, surgical resection, lobectomy or pneumonectomy is okay. And with the locally advanced like stage 3, chemo radiation is also very important. Metastatic stage 4, that's more of palliative. So platinum based chemotherapy with or without immunotherapy, like the PD and PDL1 inhibitors like nivolumab and pembrolizumab will be needed. And then okay, so with the histopathology, H&E staining of squamous cell carcinoma of the lungs. The key morphological features include the keratin pills. So you see keratin pills, the concentric layers, which shows concentric layers of the keratinized cells. It's a hallmark of well differentiated squamous cell carcinoma. And intercellular bridges, there's mosomal connections between the tumor cells, and pleomorphic nuclei, which is a variation in the nuclear size and shape with hyperchromasia. Okay, so with in general histological or histopathology of the squamous cell carcinoma of the lungs is H&E hematoxylin using stained microscopic imagery depicts the squamous cell carcinoma of the lungs. Is one of the most common types of non-small cell lung carcinoma, and it's often associated with smoking, and the tumor arises from bronchial epithelium and is characterized by keratinization and intercellular bridges. So the keratin pills observed, they are round eosinophilic. It is the pink structure is composed of concentrically arranged keratinized cells, and their presence suggests a well-differentiated squamous cell carcinoma. There's also intercellular bridges, which are thin thread-like connections between adjacent tumor cells, representing desmosomal junctions, and a hallmark of squamous cell differentiation. The third point you have to remember is the pleomorphic nuclei and hyperchromasia. So the tumor cells exhibit nuclear pleomorphism, variations in size and shape, and hyperchromasia, which is a dark staining nuclear, which indicates high mitotic activity and malignancy. So this keratosis, which is abnormal keratinization within individual cell tumors. We have the cells which undergo premature keratin formation leading to dense eosinophilic cytoplasm. And the inflammatory and necrotic background, we have tumor cells are surrounded by areas of necrosis due to rapid tumor growth, outpacing blood supply, and the chronic inflammatory infiltrates mostly lymphocytes may be present. So, what is a squamous cell carcinoma of the lung? It's a type of non-small cell lung cancer, which carcinoma which originates from bronchial epithelium and shows squamous differentiation with keratinization and intercellular bridges. And the strongest risk factor for squamous cell carcinoma of the lungs is cigarette smoking, which is the most significant risk. About 90% of the cases are linked to smoking. So, where in the lung does squamous cell carcinoma typically arise? Because it develops centrally in the main stem or segmental bronchi, which often leads to bronchial obstruction and lesions or cavitations. And histopathology, what histological feature confirms diagnosis of squamous cell carcinoma of the lungs? Three main ones are the keratin pills, intercellular bridges, and this keratosis. So, how does squamous cell carcinoma of the lungs differ histologically from adenocarcinoma of the lungs? The squamous cell carcinoma has keratinization and intercellular bridges, while the adenocarcinoma has glandular formation and mucin production. What grading system is used for in the squamous cell carcinoma? It's graded based on the differentiation and what differentiated. There is abundant keratin pills, few mitotic figures. Well, moderately differentiated squamous cell carcinoma, there are some keratinizations and more nuclear polymorphisms. And poorly differentiated squamous cell carcinomas, there's no keratin pills but high mitotic rate and very aggressive too. With the clinical and molecular features, what are some of the common symptoms of squamous cell carcinoma of the lungs? There's cough, hemoptysis, which is coughing out blood, dyspnea, just shortness of breath, chest pain, recurrent pulmonary infection due to bronchial obstruction, and also what do you think? What are the paraneoplastic syndrome? What paraneoplastic syndrome is associated with squamous cell carcinoma? Hypercalcemia due to thyroid hormone related peptide secretion leading to weakness, kidney stone, and confusion. And what are some of the mutations in squamous cell carcinoma? It's associated with mutations in the tumor suppressor gene P53 and then CDKN2A, which is cell cycle regulator, and FGFR1 amplification. So, what is the preferred treatment for squamous cell carcinoma in the lungs? Early stage, surgical resection is very important, and locally advanced squamous cell carcinoma chemoradiotherapy is also needed. Metastatic squamous cell carcinoma, platinum-based chemotherapy with or without immunotherapy, and PD-L1 inhibitors like pembrolizumab is also needed. So, squamous cell carcinoma of the lungs is smoking-related lung cancer, and typically it shows keratin pills, intercellular bridges, pleomorphic nuclei, and paraneoplastic hypercalcemia is common. The treatment includes surgery, chemotherapy, and immunotherapy. So, anaplastic carcinoma, the detailed explanation of the histopathology of anaplastic carcinoma, you realize in H&E stain, that's hematoxylin in eosin stain, there is highly aggressive poorly differentiated features suggestive of malignant tumor, and anaplastic lesions or anaplasia basically refers to lack of differentiation, meaning the tumor cells have lost their normal structure and function, making it difficult to differentiate the or determine the tissue origin. So the key histological features observed in the histopathology is that there is marked cellular pleomorphism, and the tumor cells show significant variation in size and shape, and this is a hallmark of high-grade malignancy. So the hyperchromatic irregular nuclei feature could be seen. So the nuclei appear dark, that's hyperchromatic, due to increased DNA content, and there's nuclear pleomorphism. Pleomorphism. So with different sizes and shape is also present, and some nuclei are giant multinucleated cells. There's also high mitotic activity. That's another feature too. So many tumor cells are undergoing mitosis, including the abnormal mitotic figures, tripolar or multipolar spindles, and this indicates rapid, uncontrolled tumor growth. And there's loss of normal tissue architecture. There's no clear glandular squamous or other differentiation, confirming its undifferentiated anaplastic nature. So the cells appear disorganized and infiltrative, invading the surrounding structures. Necrosis and inflammation. Some areas show necrosis due to rapid growth, rapid tumor growth outpacing its blood supply, and inflammatory cells may be present in the background. Alright, so let's try and then brainstorm more and ask questions about anaplastic carcinoma. So what is anaplastic carcinoma? From what I said, it's a poorly differentiated, highly aggressive cancer that lack features of its original tissue type, and it often grows and spreads rapidly. So why is it called anaplastic? It means without differentiation, and the tumor cells have lost their normal features and do not resemble the tissue of origin. Where is anaplastic carcinoma commonly found? It's occur in various organs, but some common types include anaplastic thyroid carcinoma, which is very common, and also anaplastic large cell lymphoma, anaplastic lung carcinoma. What are the key histological features of anaplastic carcinoma? Include marked cellular pleomorphism, variable cell shapes and sizes, hyperchromatic nuclei, dark staining, irregular nuclei, and high mitotic activity, including abnormal mitosis and necrosis and inflammation too. So how can anaplastic carcinoma be distinguished from other cancers? Unlike well-differentiated cancers, adenoma or adenocarcinomas, squamous cell carcinoma, anaplastic carcinomas, they lack glandular or squamous differentiation and has extreme nuclear pleomorphism and shows undifferentiated tumor growth patterns. And with the clinical and molecular features, what's the prognostic or prognosis of anaplastic carcinoma? It's very poor. It's very poor. A very poor prognosis due to rapid growth and early metastasis, resistance to chemotherapy and radiation, frequent local invasion, and also systemic spread. So what molecular mutations are commonly found in anaplastic carcinoma? The mutations vary by organ, but common ones include the tumor suppressor gene mutations like P53, BRAF V600E mutations in anaplastic thyroid carcinoma, MYC amplification in tumor cells. So amplification in aggressive tumors. So how is anaplastic carcinoma treated? Through multimodal therapy, depending on the site, surgery, possible radiation therapy for local control, and chemotherapy or targeted therapy has a limited response to. So anaplastic carcinoma is highly aggressive, undifferentiated cancer. Typically shows extremely pleomorphic, hyperchromatic nuclei, high mitotic rates, and necrosis. There's poor prognosis due to rapid growth and metastasis, and treatment is challenging, often requiring surgery and chemotherapy and radiation. Alright, so with the gross pathology of small cell lung carcinoma, it's usually referred to as oat cell carcinoma due to the characteristic shape of the tumor. And the key features of small cell lung carcinoma in gross pathology is that there's centrally located mass. The tumor is typically found near the hilum with or the central bronchi, and it can cause airway obstruction leading to atelectasis or post-obstructive pneumonia. So soft infiltrative and necrotic appearance is also another feature. The tumors are often soft, tan gray and polycircumscribed, indicating rapid infiltration into surrounding lung parenchyma. So areas of necrosis, there's dark regions in the image are common due to rapid growth outpacing blood supply. So excessive lymphatic and vascular spread. The tumor tends to spread early via lymphatics and blood vessels, and this contributes to poor prognosis of small cell lung carcinoma. And with the clinical and pathological aspects of small cell lung carcinoma, the epidemiology and risk factors strongly associated with smoking in 95% of the cases, more common in older male smokers, highly aggressive and metastasizes early to the liver, brain, bone, and adrenal glands. Histopathological features on microscopic examination as a H&E stain, methoxylin and eosin stain. It shows small round or oval oat-like cells and then small round oval oat-like cells with scant cytoplasm, and there is hyperchromatic nuclei with finely granular chromatin, that's salt and pepper pattern, high mitotic index, it's many dividing cells, frequent necrosis and crash artifact. Neuroendocrine differentiation also occurs, which confirmed by markers like synaptophysin, promogranin A and CD56. So the clinical presentation, there's persistent cough, dyspnea, hemoptysis, and paraneoplastic syndromes due to neuroendocrine differentiation. Example, syndrome of inappropriate ADH secretion like hyponatremia, Cushing's syndrome, like adrenocorticotropic releasing hormone secretion like hypercortisolism, and Lambert-Eaton myasthenic syndrome leading to muscle weakness. Our treatment and prognosis is highly aggressive, but initially responsive to chemotherapy and radiation, and surgery is not an option due to early metastasis, At least the median survival is less than 1 year in extensive disease. So let's summarize everything about small cell lung carcinoma, highly aggressive neuroendocrine carcinoma, ancestral located in the lung, with the gross pathologies poorly differentiated, poorly defined, infiltrative mass with necrosis and extensive lymphatic invasion. With histology, the small cells with scanty cytoplasm, high mitotic activity, and neuroendocrine markers, and paraneoplastic syndromes. We have SIADH, which is the syndrome of inappropriate ADH secretion, or leading to hyponatremia, and Cushing syndrome, Lambert's eating syndrome, with a poor prognosis is poor due to early metastasis and treated with chemotherapy and radiation. Okay, so we'll move on with others too. So with breast carcinoma, let's take a biopsy or a section of the breast tissue. Usually shows a large, firm, irregular shape and infiltrative mass, and the tumor appears to have a central area of necrosis and fibrosis, giving it pale whitish appearance, and surrounding the tumor is a yellowish adipose tissue, indicating the involvement of normal breast tissue. And the tumor has infiltrative border. Okay, so with the infiltrative border is suggestive of invasive growth, and there are areas of hemorrhage and possible ulceration which may be associated with the aggressive malignancy, and the surface appears irregular and the lesion is fixed to the surrounding tissue. So let's try and ask some questions. And so what type of carcinoma is commonly seen in the breast tissue? It's invasive ductal carcinoma. That's a common type of breast carcinoma, accounting for about 70 to 80% of the cases. So what are the gross pathological features of invasive ductal carcinoma? It typically presents as a firm, irregularly shaped, poorly circumscribed mass with a gritty structure due to desmoplastic stroma reaction, and it may show central necrosis and fibrosis leading to retracted or packed appearance of overlaying skin. And what's the significance of necrosis in breast carcinoma? Necrosis suggests rapid tumor growth and poor blood supply, which may be indicative of high grade malignancy. So comedo necrosis is characteristic of ductal carcinoma in situ. Is a precursor lesion. So how does a breast carcinoma spread? It spreads through the lymphatic routes, as axillary lymph node metastasis, which is most common, and hematogenous routes as distant metastasis to lung, bones, liver, and brain, and in direct invasion, that's local spread into surrounding breast tissue like the skin and chest wall. So what's the histopathological features that will confirm your diagnosis? The histological examination will show malignant epithelial cells forming irregular ducts or sheets, pleomorphism and high nuclear TPR. There's also increased mitotic activity and desmoplastic stroma, confirming a firm consistency, and also possible lymphovascular invasion. Okay, so what are some of the clinical signs of breast carcinoma? There's palpable lump, paleness, hard, immobile, skin dimpling due to desmoplastic reaction pulling the skin, and nipple retraction or discharge, podurans appearance, edematous skin due to lymphatic obstruction, an axillary lymphadenopathy, which is enlarged lymph nodes. How's the breast carcinoma diagnosed? The clinical examination, like palpation, inspection, and mammography, which detects the microcalcifications. Ultrasound useful for cystic and solid differentiation, and core needle biopsy is definitive histopathological diagnosis. Is immunohistochemistry for immune receptors like ARPR and HER2 receptor status. And what are the treatment options for breast carcinoma? Whether surgical options like lumpectomy or mastectomy, radiation therapy like post-surgical to eliminate residual cells, chemotherapy for aggressive or metastatic cases, and hormonal therapy if ER or PR positive. For example, tamoxifen, and targeted therapy like HER2 positive tumors give like trastuzumab. Alright. So what I discussed was basically about invasive ductal carcinoma of the breast. Okay, so we'll move on with more carcinoma histopathology. Okay, so still on the neoplasms, we'll start with breast carcinoma. Alright, so with the mind maps about breast carcinoma or neoplasms in general, one thing is if you get a tissue with a gross appearance of the specimen, it's usually irregularly shaped mass with infiltrative margins, and it's firm white to tan surface with a star-like pattern, and there's fibrotic or scarious consistency. It is characteristic of invasive ductal carcinoma, and retracted surrounding tissue suggesting of this desmoplastic stromal reaction. So there's yellow to reddish areas indicating fatty tissue and possible hemorrhage, and of course use a ruler to indicate the tumor size, which sometimes is usually around 4 to 5 cm in diameter. Alright, so what type of breast cancer does usually the tissues present or represent? And like I said in the previous tutorial, is consistent with invasive ductal carcinoma, and which is the most common form of breast cancer. And what does the stellate appearance of the tumor indicate? It indicates that star-like configuration indicates desmoplastic plastic reaction where the tumor induces fibrosis, pulling the surrounding tissue and making it feel firm and fixed. So why does the tumor appear white and firm? The white coloration is due to fibrosis and dense collagen deposition in response to tumor invasion. The firm consistency results from stromal reaction, which is the scirrhous growth. So what are the histological features of invasive ductal carcinoma? Irregular infiltrative nests of malignant epithelial cells and high nuclear pleomorphism with increased mitotic activity, desmoplastic stromal reaction, as well lymphovascular invasion in aggressive cases. So what clinical features would a patient with this tumor present with? And it's quite simple. So palpable breast lump, hard, immobile, irregular, with skin dimpling due to fibrotic retraction, nipple retraction or discharge, podoran's appearance with edema due to lymphatic obstruction, and axillary lymphadenopathy which spread to lymph nodes. And how is breast carcinoma diagnosed? Clinical examination, so mammography, which is microcalcifications, irregular mass, and ultrasound and MRI also. That's for solid versus cystic differentiation, and also core needle biopsy. That's a definitive histological confirmation, and immunochemistry to IHC for ER, PR, and HER2 markers too. So, what is the prognosis of invasive ductal carcinoma? It depends on the grade, the stage, and the receptor status. So, ER, PR positive or HER2 negative, that's the best prognosis. HER2 positive, that's more aggressive, but treatable with trastuzumab. And triple negative, like ER negative, PR negative, and HER2 negative, that's poor prognosis and high metastatic risk. And what are the treatment options? Like surgery, there's lumpectomy and mastectomy. Radiotherapy is to prevent local recurrence, and chemotherapy for aggressive cases. Hormonal therapy if ER, PR positive, and targeted therapy for HER2 positive tumors. So for a specimen indicative of breast carcinoma or highly indicative of invasive ductal carcinoma, the most common and aggressive form of breast cancer, and the stellate firm white appearance suggests extensive fibrosis and invasion due to surrounding tissues. And also early diagnosis and receptor-based treatments are crucial for management. Right, so let's go deeper into the histopathological section of an infiltrating ductal carcinoma of the breast stained with hematoxylin and eosin. So it's actually has several features. So let's break them down. So malignant epithelial cells, they are irregularly shaped ducts and nests of pleomorphic epithelial cells invading the surrounding stroma. There is nuclear pleomorphism, which is has to do with variability in nuclear size and shape, with hyperchromatic or dark staining nuclei, and there's increased mitotic activity indicating rapid proliferation. Desmoplastic stroma. The tumor is embedded in dense fibrotic tissue, leading to sclerosis, that's the hard consistency, and fibrosis causes distortion and compression of the malignant ducts, contributing to skin dimpling in clinical presentation. With the invasive growth pattern, the absence of a well-defined basement membrane, indicating that the tumor has invaded beyond the ductal structures, and the cancer cells infiltrating as irregular pods, nests, and single cells. So lymphovascular invasion is also possible but not clearly seen. So in some cases it shows tumor emboli within the lymphatic or vascular channels, facilitating metastasis. So let's try and then brainstorm more by asking some few questions. So what is infiltrating ductal carcinoma? Infiltrating ductal carcinoma is the most common cause of breast cancer in about 70 to 80% of cases, arising from the terminal duct lobular unit and infiltrating the surrounding stroma. So how does infiltrating ductal carcinoma appear microscopically? Usually, like I said, irregular malignant ductal cells infiltrating the fibrotic stroma, and also high nuclear pleomorphism and mitotic figures. Also dense desmoplastic stroma, giving the tumor a firm sclerous structure texture. And how does the infiltrating ductal carcinoma differ from ductal carcinoma in situ? So infiltrating ductal carcinoma, as the name goes, is invasive and lacks a basement membrane, but the ductal carcinoma in situ is non-invasive and remains confined within the ductal system. And what molecular markers are used in infiltrating ductal carcinoma diagnosis? The markers that we use are the PR receptor, estrogen receptor, and progesterone receptor. So hormone receptor, whether positive tumors have better prognosis and respond to hormonal therapy. HER2 receptor, that's human epithelial growth factor receptor 2. HER2 receptor positive tumors are more aggressive than, but they respond to trastuzumab, that's the Herceptin, and Ki-67 proliferative index, as high Ki-67 indicates increased tumor aggressiveness. So what are the risk factors for infiltrating ductal carcinoma? We have genetic predisposition like BRCA1, BRCA2 mutations, BRCA1-2 mutations, hormonal factors like estrogen exposure, late menopause, hormone replacement therapy, and also lifestyle factors like obesity, alcohol consumption. So what are the clinical features of infiltrating ductal carcinoma? Well, the females will present with a mass, or wherever, if gynecomastia, they will present with a mass which is hard, irregular, and immobile, and skin retraction or dimpling due to fibrosis, pod orange appearance, edematous thickened skin, axillary lymphadenopathy if there's metastatic spread. And what's the prognosis of infiltrating ductal carcinoma? It's favorable only if HER2 is negative and estrogen progesterone receptor is positive. And there's poor diagnosis in triple negative in infiltrating ductal carcinoma, where you have the ERPR or HER2 or negative. And lymph node involvement even worsens the prognosis. And how is infiltrating ductal carcinoma treated? Right, with the treatment of infiltrating ductal carcinoma, for surgery, we do lumpectomy or mastectomy and radiation therapy to prevent local recurrence, and also chemotherapy in aggressive or metastatic cases, and also hormonal therapy for ER/PR positive tumors, for example, giving tamoxifen, and also targeted therapy for HER2 positive cases like trastuzumab. Alright, so with the histopathological slide of infiltrating ductal carcinoma, it shows the hallmark features of invasive malignant ductal epithelial cells infiltrating fibrotic stroma, and the most common breast cancer subtype, and its prognosis depends on the hormonal receptor status or HER2 expression and tumor stage. Alright, so now let's move to the colon. Say you get a specimen, a gross pathological specimen of the colon showing multiple adenomatous polyps. So having something like that, the colon will appear kind of thickened and irregular with numerous protruding polypoid lesions of varying sizes distributed throughout the mucosal surface. So some polyps are sessile, that's just broad base, while others are pedunculated, that's tall. And the background, okay, so let's take any example like a background mucosa which shows folds characteristic of normal colon structure will become slightly distorted due to the presence of multiple growths. And the diagnosis of colon adenomatous polyps are precancerous lesions and can progress to colorectal cancer, especially in conditions like familial adenomatous polyposis. Alright, so quick few examples and few questions. What are adenomatous polyps? They are benign, like I said, benign epithelial neoplasms of the colon that arise from the glandular tissue and have the potential to progress to adenocarcinoma. And what are the types of adenomas? We have the tubular adenoma, which is the most common, less than 4%, 5% risk of malignancy. Villous adenoma is the highest risk, about 40% chance of malignancy, and tubulovillous adenoma, which is the intermediate risk. Okay, so what condition is associated with multiple adenomas. As yes, so like I said, familial adenomatous polyposis. It's a hereditary condition caused by mutations in the AP antigen presenting cell gene, and it leads to hundreds and thousands of colorectal adenomas and an almost 100% risk of colorectal cancer if untreated. And how do the adenomas progress to colorectal cancer? So let's take the sequence. So adenoma carcinoma sequence involves genetic mutation. So APC mutation, which is an early event, KRAS mutation, which is an intermediate adenoma stage, and then the TP53 mutation, so the tumor suppressor gene P53 mutation 2, which is a late stage leading to invasive carcinoma. And what are the risk factors for adenoma development? Because age more than 50 years, genetic predisposition, Lynch syndrome, FAP, and then high fat, low fiber diet, obesity, smoking, alcohol consumption could all lead to it. And what are the clinical symptoms of chronic adenomas? Actually, they are often asymptomatic, but rectal bleeding could occur, hematochezia, iron deficiency anemia, which is, and then even diarrhea. So changing bowel habits with that diarrhea or constipation. The iron deficiency anemia could be from occult bleeding. So how are the adenomas detected and managed? We have colonoscopy, which is a gold standard with biopsy, and polypectomy during colonoscopy for small lesions, and surgical colectomy in FAP cases or large high-grade dysplastic adenomas. What is the significance of detecting adenomatous polyps early? So early removal of adenomas significantly reduces colorectal cancer risk, and regular colonoscopy screening is recommended, especially in individuals with family history. So this gross specimen of colon demonstrates multiple adenomatous polyps indicative of a precancerous condition, and the presence of numerous polyps suggests a high risk of colorectal cancer, particularly if associated with familial adenomatous polyposis. And regular screening and early intervention are critical in preventing malignant transformation. Alright, so let's look at another gross pathology or pathological specimen of the colon, which has multiple polyps of different morphological types. So it could be of sessile polyp or pedunculated polyp, and even fungating and the rest. Yeah, so the sessile is a broad-based dome-shaped polyp without a stalk, and with a pedunculated, it's is a polyp with a distinct stalk resembling a mushroom-like projection. So both types of polyps are commonly found in large intestines and can be neoplastic, whether adenomatous or non-neoplastic, that's hyperplastic or inflammatory or hematomatous. Alright, so the types of colonic polyps. Let's look at some key things or some key concepts. So with the neoplastic or precancerous polyps, we have adenomatous polyps or adenomas, which is tubulovillous, which indicates risk of malignancy. And we have the serrated polyps, which is sessile serrated adenomas associated with um, BRAF mutation. And for the non-neoplastic benign polyps, we have the hyperplastic polyps, which is most common, small, less than 5 millimeters, no malignant potential, and the inflammatory polyps, which is seen in inflammatory bowel disease like ulcerative colitis. So hematomatous polyps is usually associated with PJ syndrome and juvenile polyposis. And one thing is that just get to know the differences between the sessile and the pedunculated polyps. So among them, we have the shape, the risk of malignancy, the growth potential, and the removal difficulty. So with the sessile polyps and the pedunculated, with the sessile we have the flat, broad-based, and the stalk mushroom-like. For the pedunculated, risk of malignancy is higher for sessile polyps than the pedunculated, which is a bit lower if tubular adenoma is present, but higher in sessile polyps, especially if serrated or villous adenomas. And then with the growth potential, it spreads along the mucosa, and with the growth potential for the pedunculated polyp, it grows outward. So there's removal difficulty. It's harder to remove for the sessile polyps, but easier to remove for the pedunculated. So the sessile polyps are more concerning because they are harder to detect and remove and have a higher risk of malignant transformation. All right, so the clinical significance, we have adenomatous polyps, um, and if a patient has these adenomatous polyps, it can progress to colorectal cancer via the adenoma carcinoma sequence I talked about earlier on. Yeah, with the final stage to do with the suppression of the or mutation of the p53 gene, leading to proliferation of the cells and leading to cancer. So, regular colonoscopy is actually necessary for early detection and removal of polyps, and polypectomy is performed for both the sessile and the pedunculated polyps to prevent progression. So, for colonic specimens with sessile pedunculated polyps, different morphological forms of the colorectal polyps, and that will emphasize its clinical significance in colorectal cancer prevention. And the distinction between these types is crucial, as sessile polyps carry a higher malignant potential and require careful monitoring. Alright, so now let's go deeper. Let's take the histology of colonic adenoma or polyp. So with an H&E stain of a colonic adenoma or polyp, there's glandular proliferation with crowded dysplastic epithelium, elongated hyperchromatic nuclei with lots of normal mucosal architecture, a finger-like projection of this plastic glandular tissue, which is characteristic of adenomatous polyps, and pseudostratification of nuclei indicating of low-grade dysplasia. Alright, so with the key features of colonic adenomas, they are benign neoplastic polyps with the potential to progress to colorectal cancer, like I said, and they use the adenoma carcinoma sequence, and the classification of the adenomas depends on what I talked about. So whether it's tubular adenoma, villous adenoma, tubulovillous adenoma. So the tubular is usually the most common, which is composed of tightly packed tubules. Villous adenomas higher malignant potential, long finger-like projections, and the tubulovillous adenomas, which is mixed has mixed features. So with the histological features, the normal colonic mucosa, the architecture is organized crypts, the nuclei basally located, small and uniform, and the mucin production is present. There's mitotic activity, which is low, but the adenomatous polyps is disorganized, elongated glands. That's for the architecture, but the nuclei are enlarged, hyperchromatic, and pseudo-stratified. The mucin production is reduced and mitotic activities increase. So with the clinical significance, adenomas are precancerous and can progress to adenocarcinoma through the adenocarcinoma sequence. And the risk factors for malignant transformation, the size is more than 1 cm, villous components, and high-grade dysplasia. And the surveillance colonoscopy is recommended for early detection and removal. So this colonic adenoma is a precursor lesion to colonic cancer, and identification and removal of the adenomatous polyps via colonoscopy are crucial in colorectal cancer prevention. Right, so now let's focus on adenocarcinoma of the colon. So let's take a gross pathology of the of the colonic adenocarcinoma. It's fungating or straight head mass, and it has irregular borders and central necrosis. The tumor usually appears to have luminal narrowing, which may lead to obstruction, and the surrounding mucosa appears relatively normal but may show dysplastic changes. So with the colorectal adenocarcinomas, um, rectal carcinoma is the most common malignancy of the GIT, usually arising from adenomatous polyps via the adenoma carcinoma sequence. And the gross morphological pattern of the colorectal cancer, it's exophytic or fungating. So the polypoid mass protruding into the lumen, which is more common in the right colon, and illustrating or infiltrative. There's an annular constricting lesion causing a napkin ring appearance, which is more common in the left colon, and mucinous. The tumor producing excess mucus, often seen in poorly differentiated cancers. So more on the morphological features, atypical glandular structures invading the mucosa and muscularis propria, and there's high nuclear to cytoplasmic ratio with hyperchromatic pleomorphic nuclei and loss of normal glandular architecture and presence of necrotic debris within the glands. That's the necrosis. Desmoplastic stroma, which is fibrotic tissue reaction, also occurs surrounding invasive glands. And the risk factors for colorectal carcinoma, we have genetic factors like I talked about earlier on: APC mutation, microsatellite and instability, Lynch syndrome, KRAS, TP, P53 mutations, environmental lifestyle factors like low fiber diet, high fat diet, smoking, alcohol consumption, obesity, sedentary lifestyle, pre-existing conditions like inflammatory bowel disease, whether Crohn's disease or ulcerative colitis, and also colonic adenomas, especially villous adenomas too. And then with a clinical presentation, whether right-sided, the proximal colon, there's fatigue, iron deficiency, anemia, and called bleeding, weight loss, and with the left-sided, there's altered bowel habits, constipation, diarrhea, hematochezia, obstruction. Or the rectal involvement, there's tenesmus, incomplete evacuation, rectal bleeding. Diagnosis and staging, we have colonoscopy with biopsy, which is a gold standard, and carcinoembryonic antigen. We have the tumor marker for prognosis and monitoring recurrence with imaging like CT, MRI, PET scan, CT scan, staging, and metastasis evaluation. So with the stage, we have the TNM. So the T standing for the TNM staging system. The T stands for tumor invasion depth. The N, the lymph node involvement, and the M has to do with the distant metastasis, liver, lung. And with the management, we have the surgical resection, colectomy for localized disease, and chemotherapy, FOLFOX, for FURI for advanced metastatic diseases, and targeted therapy, FEGFR inhibitors, VEGF inhibitors based on molecular profiling, and also immunotherapy, which are checkpoint inhibitors for MSIH tumors. So with colonic carcinoma, it's the most common GI malignancy, and early detection via colonoscopy or screening significantly improves the prognosis, as colorectal cancer often leads to progressive adenocarcinoma sequence and finally leads to death. Okay, and I think we've spoken about a lot. So yes. Alright, so I think we can go ahead with other histopathology of invasive colonic adenocarcinomas. So it's when staying with HNE, it has this, like I talked about, this plastic glandular structures with irregular, crowded, and cribriform architecture with infiltrative growth pattern, and the malignant glands are penetrating through the muscularis propria into the submucosa and surrounding stroma. And there's a lot of normal glandular architecture. It's marked nuclear pleomorphism and also hyperchromatic nuclei. So there's moplastic reactions, for example, the surrounding fibrotic stroma is dense and also indicative of stromal response to tumor invasion. And tumor emboli in the lymphovascular spaces would definitely suggest potential for metastasis. Alright. So, the pathological features of histopathology of invasive colonic adenocarcinoma, the cellular morphology is atypical glandular structures with loss of polarity and with a high nuclear to cytoplasmic ratio. You have hyperchromatic pleomorphic nuclei, increased mitotic activity, and presence of abnormal mitotic figures. We have the necrotic debris with glandular lumina or dirty necrosis, a classic feature. And invasion and spread, it's beyond the muscularis propria. Defining features of invasive carcinoma, and with the lymphovascular invasion, the tumor cells invading the blood or lymphatic vessels. You have the perineural invasion, and then tumor cells seen surrounding nerves, indicating aggressive behavior. With the clinical implications, the staging, the TNM staging: T1 limited to the submucosa, T2 the muscularis propria, T3 extends beyond the muscularis propria into the pre-colonic tissue, and T4 invades the visceral, peritoneal or adjacent organs. The prognosis or prognostic factors includes the depth of invasion and the lymph node involvement, and these are key prognostic indicators. And lymphovascular invasion to increases metastatic potential. Mismatch repair deficiency like DMMR or MSIH indicates better prognosis and also responsiveness to immunotherapy. Alright, so histopathology of colonic adenocarcinoma. I've already talked about them, about how irregularly infiltrating malignant glands are seen with surrounding the desmoplastic stroma, and how the tumor exhibits marked nuclear pleomorphism, hyperchromasia, and loss of normal glandular structure with cribriform and angulated glands suggestive of high-grade tumor, and also with the fibrotic stromal reaction as desmoplasia is prominent and present. Alright, so now let's move to the liver. So with liver adenoma, it's actually well circumscribed, solitary yellowish tan nodule, and the lesion is located at the peripheral liver parenchyma and lacks significant necrosis, hemorrhage, or central scaling, which are features that would suggest other liver tumors, and the surrounding liver parenchyma appears normal, suggesting it is not associated with cirrhosis. Alright, so that is something about it. Hepatic adenoma is a benign liver tumor derived from hepatocytes, and it's very common in women, young women, often associated with oral contraceptive use. And other risk factors include steroid use, anabolic steroid use, glycogen storage diseases like type 1, type 2, and metabolic syndrome too. With a gross appearance, like I said, solitary was circumscribed, about 5 to 15 cm, yellow to tan color due to fat and glycogen content, no fibrosis or no fibrous capsule, but sharply demarcated. I may have hemorrhagic areas, especially in larger adenomas, but no bile duct proliferation or cirrhosis, differentiating it from the focal nodular hyperplasia. And with the histological features, like I said, there are sheets of benign hepatocytes with abundant cytoplasm, no portal triad, bile duct or significant fibrosis, minimal atypia, no significant mitotic activity. Steatosis may be present. With the clinical significance, generally asymptomatic but may present at the right with a right upper quadrant pain if large, with acute hemorrhage if ruptured, leading to intraperitoneal bleeding, and risk of malignant transformation to hepatocellular carcinoma is low but increased in larger adenomas, more than 5 cm in beta catenin mutated adenomas. And with the management, you discontinue hormonal therapy if applicable, and surgical resection if the lesion is more than 5 cm. A risk of rupture and malignant transformation, and they are symptomatic or beta catenin mutated adenomas. So one thing is that hepatic adenomas is a benign hepatic tumor with potential for hemorrhage and low rates of malignancy, and proper diagnosis and management are crucial, especially in high risk patients. Now, with a more thorough thing, let's move to hepatocellular carcinoma. The gross pathology is really, you see a large necrotic mass, and the tumor has irregular borders, yellow tan appearance, and several areas of necrosis and even hemorrhage, and multiple smaller satellite nodules suggestive of intrahepatic spread. And the liver parenchyma appears coarsely nodular, indicating underlying cirrhosis, which is a major risk factor of hepatocellular carcinoma. Right, so hepatocellular carcinoma, whether from Hep B, Hep C, alcoholic liver disease, non-alcoholic fatty liver disease, cirrhosis, aflatoxin exposure, hemochromatosis, all these could lead to it. Alright, so renal cell carcinoma. For renal cell carcinoma, the gross pathology, it's large yellow orange tumor with areas of hemorrhage and necrosis. The term kidney adenocarcinoma is not commonly used. So the malignant epithelial tumor of the kidney is renal cell carcinoma. It usually the tumor appears well circumscribed, but it's infiltrating the renal parenchyma, and it's located usually at the renal cortex. And characteristic of renal cell carcinoma, the upper pole of the kidney appears to be affected, and areas of cystic degeneration and hemorrhage are evident. Okay, so the features I talked about: golden yellow appearance due to high lipid and glycogen content with areas of necrosis, hemorrhage, and cystic changes, and it's pansal good pattern can invade the renal vein. Alright, so the clear cell renal cell carcinoma, they are large, clear cytoplasm rich in lipid and glycogen when you're looking at it microscopically. And papillary renal cell carcinoma, those papillary structures, they have foaming, they form with foamy macrophages and often linked to MET gene mutations. Chromophobe renal cell carcinoma is just about 5%, large eosinophilic cells with perinuclear halos, arises from intercalated cells of collecting ducts. Clinical presentation: the classic triad, hematuria, flank pain, palpable mass, and is seen usually in less than 10% of cases. And the paraneoplastic syndromes is common, which is the erythrocytosis, hypercalcemia, hypertension, Cushing syndrome. And the diagnosis, of course, is imaging, renal biopsy, immunohistochemistry, and the prognosis depends on the stage and the metastasis too. And then metastasis to the lungs, bone, liver, brain is common, and surgical resection, nephrectomy is the main treatment. Targeted therapy, like vascular endothelial growth factor inhibitors like sunitinib is used for metastatic renal cell carcinoma. Right, no, now intestinal lipoma, we take one. It's simple to identify. It's well circumscribed yellowish mass protruding into the lumen and appears soft, smooth, encapsulated with a benign fatty tumor, which is a lipoma, and is located in the submucosa, with which is a common site of intestinal lipomas, and overlying mucosa appears intact without any ulcerations. They are benign tumors composed of mature adipocytes or adipose tissues, and they're actually rare, count for less than 5% of all the benign intestinal tumors, and typically affects adults like 40 to 70 years. And the prognosis, once it's more asymptomatic lipomas, and that one no treatment is needed, but for the symptomatic large ones like more than 4 cm, endoscopic resection or surgical resection to prevent complications like intussusception, obstruction, or even bleeding. Alright, so let's look at lipoma of the leg. It's usually soft subcutaneous swelling on the leg with multiple raised, well-defined masses. The masses appear smooth, mobile, that is on palpation, encapsulated, which is characteristic of lipomas. If there's a planned excision, you place in some surgical markings also. Alright, so the histopathology of small intestines lipomas, actually you see with the H&E stain will be well circumscribed mass of mature adipocytes or adipose tissues seen beneath the mucosa, and the tumor is usually encapsulated, compressing the surrounding structures. Okay, so intestinal lipoma, like I said, benign adipose tumor of the intestinal tract, and is usually harmless, but large lesions may cause intussusception or bleeding, requiring surgical or endoscopic removal. Right. So now let's look at a typical histopathology of lipoma. With an H&E stain, you see that it shows mature adipocytes arranged in lobules, and each adipocyte has a large clear cytoplasm, this lipid-filled vacuum, and a periphery of these cells that displays nucleus. So there are no cellular atypia, pleomorphism, or mitotic figures indicative of just benign nature of these lipomas. And can I say the features are well encapsulated, often within the thin fibrous capsule. Is composed of mature adipose tissues, minimal vascularity, no necrosis or cellular atypia, really not liposarcoma, and also may contain fibrocepta, but does not show significant inflammation. And the clinical correlation, lipomas are benign mesenchymal tumors of adipose tissue, and the most common soft tissues are found in the subcutaneous tissue like the trunk, neck, arms, thighs. Usually symptomatic, but larger lipomas may cause compression symptoms, and confirms really not malignant transformation. Alright, so lipomas, liposarcomas, lipomas, the cells are mature adipocytes, encapsulation is well encapsulated, but mitosis, necrosis, pleomorphism are absent. But for liposarcoma, the cells, atypical lipoblast are seen. For encapsulation, it has this infiltrative growth, and mitosis is present, necrosis may be present, and also pleomorphism are usually present. Alright, so the gross pathology of liposarcoma is that it's liposarcoma, like I said, it's a malignant soft tissue tumor originating from adipose tissues, and with a gross appearance of gross specimen, it will definitely show large lobulated mass with a yellow fatty appearance, and firm areas with fibrous bands indicative of um, heterogeneity, and there's possible necrotic or hemorrhagic foci, which is suggestive of high-grade malignancy. So the major features has a large size, larger than the benign lipomas, lobulated and infiltrative growth, which lack well-defined capsules, heterogeneous consistency, which is firm, fibrous, and sometimes myxoid or necrotic areas, a deep-seated location, often found in retroperitoneum extremities or deep soft tissues. All right, so let's move on to the microscopic pathology of liposarcoma. The histopathological features, you could see that there is the presence of lipoblasts, which are cells with multi-vacuolated cytoplasm and indented or scalloped nuclei, characteristic of liposarcoma. And there's variability in the cell size. That's pleomorphic hyperchromatic nuclei with increased mitotic activity in aggressive types, and myxoid background. If there's myxoid liposarcoma, it has this chicken wire vasculature and mucinoid stroma in the myxoid liposarcoma, and scattered fibrosepta and tumor cells, which is infiltrative nuclear tumor growth rather than encapsulated structure. All right, so with this, surgical excision is a primary treatment, radiotherapy, chemotherapy for high risk metastatic cases, and prognosis varies depending on the subtype, whether pleomorphic, differentiated liposarcomas have worse outcomes too. Alright, so with the high magnification of histopathology of liposarcoma, like I said, there will be lipoblasts, pleomorphic cells, and hyperchromatic nuclei, and also increased mitotic activity. This presence of actively dividing cells indicating of malignant potential, and also abnormal stroma, where you have the myxoid background in some areas, characteristic of myxoid liposarcoma, and vascular pattern may resemble chicken wire capillaries. Alright, so now leiomyomas or leiomyomata. Let's move to the uterus. So when you take a gross specimen and you want to analyze it for with uterine leiomyoma or leiomyomata, we see that they are well circumscribed and there are multiple firm white nodules within the myometrium with variability in the size. Some are small white, no white. Others are larger, deformed. The uterine contour, and we have this well cut surface. Well surface. It's more of a characteristic feature of leiomyomata or leiomyomas, and intramural submucosal and subserosal locations are also evident. With the classification is based on the location, so submucosal is beneath the endometrium. It can cause heavy menstrual bleeding. Intramural is embedded within the myometrium, which is most common in the subserosal beneath the serosal surface of the uterus, and can grow outward too. Okay, so usually clinical features: heavy menstrual bleeding, pelvic pain or pelvic pressure, fertility, compression symptoms, and several others. With leiomyoma in the small intestines, the smooth muscles of the small intestines. The one too is also well circumscribed, firm, smooth mass protruding into the lumen, usually submucosal origin. The overlying mucosa appears stressed but intact, and no ulceration or necrosis, which distinguishes it from malignant smooth muscle tumors like the leiomyosarcomas too. And with the clinical features of small intestinal leiomyomas, this is symptomatic. Well, intestinal obstruction, that is if it is very large, and gastrointestinal bleeding, that is due to mucosal erosion, intussusception acts as a lead point too. And like I said, the Histopathological features, of course, it wouldn't be visible in the gross specimen, but they are spindle-shaped smooth muscle cells arranged in interlacing fascicles, and there's a band of nuclear features with minimal mitotic activity, and no cellular atypia or necrosis could be seen. So, differential diagnosis, of course, leiomyosarcoma will come into your mind, gastrointestinal stroma tumors and neurofibroma to come into mind. All right. So with the sarcoma, the a malignant mesenchymal tumor, let's take a microscopic um or histopathology of any sarcoma. Pleomorphic, there will be spindle-shaped cells arranged in haphazard and intercalating patterns. There will be hyperchromatic nuclei with high nuclear to cytoplasmic ratio, increased mitotic activity, often with abnormal mitotic figures, and nuclear necrosis may be present with variable collagen disposition or deposition, and depending on the type of sarcoma. And with the diagnostic points, the sarcomas are aggressive tumor originating from mesenchymal tumors like muscle, fat bone, and cartilage. And also, with the differentiation from benign counterparts, unlike the leiomyomas or the lipomas, the sarcomas are marked nuclear atypia, mitosis, and necrosis could be present too. Now, with the high-powered microscopic features, you could see the pleomorphic spindle-shaped cells, the hyperchromatic cells, increased mitotic activity by looking at the abnormal mitotic figures and coarse chromatin and prominent nucleoli in some cells and areas of necrosis too. All right, so I think we'll move on to other structures like the bones. So let's take osteosarcoma, a disease femur affected by osteosarcoma. So you see, with this, there's this appearance of centered brackets like symbol at the part of the femur, and you could just know that once it's irregular excessive growth, it could suggest osteosarcoma, and it's as a large mass extending from the femur showing aggressive bone destruction and formation. You could think of an osteosarcoma, and the lesion, once it's a bone, of course you can think of benign, but if it extends to other areas, and is that you could have osteosarcoma as one of your differentials. So what is an osteosarcoma? It's a malignant bone tumor which typically affects long bones like the femur, leading to abnormal and excessive bone growth. And what are the abnormalities that are visible in the femur? You could notice that there will be irregular bone growth, expansion, and areas of destruction, typical of aggressive osteosarcomas. And also, why do we usually place a scale bar when you are measuring these if you have a specimen like that? So it's just a reference to measure the size of the femur and extent of the osteosarcoma. And the common symptoms of osteosarcomas like pain, swelling, limited joint movement, and fractures due to weakened bone structure. And who is most at risk of developing osteosarcoma? Of course, primarily affects children, teenagers, young adults during growth spurs. Okay, so osteosarcoma, when you look at the histopathology, and H and E staining, this displays pink purple hues, which is characteristic of the H and E staining, and they are spindle-shaped malignant cells scattered throughout the image. They usually disorganized and chaotic with pleomorphic varied size nuclei indicative of aggressive cancerous growth, and the presence of osteoid matrix pink areas produced with malignant osteoblast, and its key feature of osteosarcoma. And some regions show increased cellularity, is indicative of high proliferation. Alright, so with undifferentiated sarcoma H&E slide, like for histopathology, you could see high degree of cellular pleomorphism and a dense distribution of cells with numerous hyperchromatic dark staining nuclei, and the stroma will appear disorganized, and the mitotic figures will be indicative of high proliferation, with the presence of spindle-shaped and round cells mixed together is characteristic of undifferentiated sarcoma. Okay, so now let's move to ovarian teratoma, like a dermoid cyst. So with the gross pathological specimen, usually consists of a large irregular shaped mass with various tissues inside, and could be hair strands, which is typical feature of dermoid cysts, and there are solid cystic areas with yellowish fatty material suggestive of the presence of sebaceous glands, and parts appear cartilaginous or bony, indicative of differentiated tissue components, and thus ovarian tumor, teratomas, or thymoid. So when you look at several, like for ovarian teratomas or dermoid cyst, it's rounded cystic structure with thick wall, and the inner lining is smooth pan-colored appearance with some whitish calcified material and the presence of solid cystic components, which is characteristic of dermoid cyst. And the white structures inside may represent teeth or calcifications, which are commonly found in teratomas. Alright, so the newborn with large mass located at the sacrococcygeal region, the mass is bulky, vascularized, or translucent, indicative of a tumor with cystic and solid components, and of course medical care, intubation, monitoring devices, supportive care are all needed as they prepare for surgery, and that's a typical case of sacrococcygeal teratoma. So sacrococcygeal teratoma is a germ cell tumor that develops at the base of the coccyx or the tailbone, and it's the most common tumor in newborns. Appears in 1 in 35,000 or 40,000 beds, and arises from pluripotent germ cells and can form multiple types of tissues, which such as the skin, the hair, the muscles, bone, and sometimes the neural tissue. And there are several types: type 1, type 2, type 3, type 4. Alright, so when you look at a cross section, you see multiple cystic spaces and solid components, and the solid areas appear to have mixed tissues, cartilage, fat, possibly neuronal and glandular tissue, and the cystic areas contain fluid or mucin. Is common in teratomas, and spinal column is also visible, indicative of the tumor located relative to the sacrococcygeal region. Alright, so when you take a histological section of a teratoma stained with H&E, you see multiple differentiated tissue types, which is characteristic of teratomas. The upper region containing keratinized stratified squamous epithelium, likely representing the skin, and lower portions with features of glandular or cystic structures, possibly representing cartilage or other mesenchymal elements. Okay, so with that, there is multilinear differentiation, which contains ectodermal, mesodermal, and endodermal elements. which is common tissues like skin, hair follicles, cartilage, bone, neuronal tissue, and glands. Could be mature, immature teratomas, mature ones with well differentiated skin, hair, fat, glands, and immature containing primitive neuroepithelial embryonic tissues with malignant potential. HNE staining of the pink lesions and purple, blue, nuclei, cystic or gland-like species. And the common locations are the ovaries, the testes, the sacrococcygeal regions too, and could be benign or malignant. Um, is mature teratomas usually benign. Immature teratomas are aggressive and require chemotherapy. Alright, so let's move on to a hemangioma, the histological section of a hemangioma stained with H&E, and you see there will be numerous blood vessels seen, which is characteristic of the hemangiomas. The vessels are lined with endothelial cells which appear congested with erythrocytes. Alright, so the key histological features are the vascular proliferation, and there are several subtypes. So the vascular proliferation, capillary size, and cavernous blood vessels, endothelial lined spaces filled with blood, so red blood cells will be seen. And the types of hemangiomas, it could be capillary, cavernous, or mixed type hemangiomas. And with the capillaries, composed of small capillaries in the lobular arrangements. With the cavernous, they are large, dilated vascular spaces with thin walls. And with the mixed type hemangiomas, there's a combination of both the capillary and the cavernous elements. And you can see the pink regions, the eosinophilic stroma, and the vessels the vessel was, and red areas are congested blood with vascular within the vascular space, and flat endothelial cells line the vascular structures. All right, and if you see the hemangiomas, of course, the benign vascular tumor and proliferation, whether capillary or cavernous hemangiomas, could be seen, and numerous erythrocytes to reflects the red stain appearance too. Alright, so that ends several neoplasms and histopathology and description of some of these specimens too.